Hello, everyone. My name's Solomay Tibabu, and I'm the host of Going Digital Behavioral Health Tech. I'm really excited for this conversation with Dr. Manojwala, Chief Medical Officer of Dario Health. Welcome.
Thank you. Yeah, it's great. It's really great to be back with you again for Going Digital. You've really, once again, put together an awesome lineup of folks and some topics that are really exciting and relevant. So I got to tell you, I'm super excited about the conference this year.
Thanks so much. It means a lot. And I'm thrilled to have you as our featured speaker. So before we jump in, can you share with our audience a little bit of background, your role, company?
Sure. Yeah. And I'll do it for them since you and I have known each other for years. So it's kind of, it's a little weird introducing myself to you. But for everybody else, I'm Omar Manojwala. I'm a psychiatrist by background. I've spent my career helping people with behavioral health conditions in many different settings: community, public health, private practice, inpatient, outpatient, and digital as well. I'm the Chief Medical Officer for Dario Health, which is multi-condition digital therapeutic. And I'm really passionate about using digital approaches to help people do things that get them healthy at scale, to make life easy for them. And so I've been with Dario Health for a little over 2 years now, and so that's me in a nutshell.
Excellent. Dr. Manojwala, I know you've got immense experience beyond just the intro you provided. So I'm really excited to dig into this topic around the state of digital mental health. To set the foundation, maybe you can share a little bit about what is the current state of mental health solutions for payers today in particular.
Yeah, and you know from my background that I spent almost the last 10 years designing and building solutions that were adopted at scale by many of the nation's largest payers and many regional payers and even some state level payers across lines of business, commercial, Medicare, Medicaid, exchange, full risk environments and ASO environments. And so, to answer your question about, which I think it's a great question, what's the current state of mental health for payers? I think it really does differ by line of business, by those target populations, and also by the risk scenarios that payers are operating in, and also it has some contextual challenges around emerging or pseudo emerging from the COVID pandemic. But there are some themes that permeate throughout all of that, and then there are some specialized characteristics that are present in each of those areas. First, I think the first and foremost, the biggest challenge that payers face today, regardless of what line of business or kind of what problems they're trying to solve, is that when it comes to mental health solutions, especially digital, but in general, is that there's no real way for payers to know what they are buying. And so you can imagine being, in their situation where they had been partnered with maybe managed behavioral health organizations, which were very antiquated models and care restriction kinds of models that were really producing questionable value, I think. And then at the same time, navigating this tension about, do we insource it? So then they insource it and face many of the similar problems. They try to integrate it. Then they look to vendors and partners to try to solve this space. And as they evaluate it, they're operating in ecosystem, many, often venture-backed kinds of digital or hybrid sorts of solutions. And they're on paper, they're all amazing. They all have incredible net promoter scores, and they're all really driving incredible results. And then they run a few pilots of these solutions, and then it turns out maybe nobody's using them, or the shine wears off, and then they try again. And so the more mature kind of strategic health plans, the 5 or 6 that are out there, are getting more sophisticated about digital strategy and how they're evaluating things. But at the end of the day, they're all facing this number one problem, which is they don't know what they're buying, and it's very, very hard to evaluate what they're buying. And that would be sort of the first thing And then I think, and by the way, that alone is a huge problem. But then kind of next level down is there's a real difficulty differentiating, because there's been this sense that everything should be cognitive behavioral therapy. Cognitive behavioral therapy is very research. Everybody says they're doing that. How many people are doing it? Then if you do actually deploy that the way it's deployed academically, does anybody actually use it? And then there's also this recognition that digital alone, there are some solutions out there that are pure digital. They're interesting, I think. But there's really a need for human contact. And so coaching is added in as a way of driving down costs compared to, say, therapy or psychiatrist utilization or prescriber utilization. And so then coaching gets embedded. So then how do you evaluate the quality of coaching? Everybody says they have these unique capabilities in this space, but are they really differentiated? And then how do you actually monitor what is happening? Folks are going to market with, I think, very limited engagement data. And so that's another kind of a third level challenge. Then below that, and I know I'm painting a very grim picture, but in some ways the picture is grim, because mental health has gotten worse. And yet at the same time, the solutions that are being deployed against them are becoming more and more difficult to evaluate. The space is getting very crowded, and the differentiation appears, at least to the folks I'm talking, strategic folks inside the plans, as being more and more difficult to discern winners and losers. So then on top of that, you've got challenges around integration, which I've shared previously with you is a word that is so nebulous as to be almost meaningless. So I'll be more specific about it. Integration with clinical platforms, integration with EHRs, integration with other solutions that the health plan may be partnering with, is really, really difficult, because there's so many different formats, and there's a lot of complexity around delivering data and intelligence in ways that don't disrupt the clinical, disrupt the workflows of the people that work at the health plans, the care managers, disrupt the workflows downstream of the providers. And so there's a problem with data integration. There's also a problem with clinical integration, where, mental health conditions, we've been talking a lot. In fact, at the conference, the last few conferences that you've had, we've talked a lot about how behavioral health conditions make physical conditions worse and vice versa. And yet there's no real clinical integration between those pieces as well. And that's another challenge. And then finally, I would say, in response to this question about, what's the current state of mental health solutions for payers today, is everybody's hyping their networks. We've got the best network, we've got a proprietary network. But when you talk to these doctors and others, they're working for all of them. There's really not any major difference in how they operate. And so, we continue to face this problem I brought up before, which is the myth of the differentiated network. And not to say that networks can't differentiate, but let's be honest, most don't. So that's the state of mental health solutions for payers today. It's a real mess. It's really, really hard to navigate, and yet they have to. It has to be solved. It's a moral crisis. It's a ethical crisis. It's a cost crisis, and it has to be solved. So, if you're a payer today, I think everyone, should appreciate the complexity that you face in trying to figure all this out. Yeah.
Right. For all the reasons you just outlined, it really is going to take all of the stakeholders, in our audience, as we discussed earlier, with payers, providers, innovators, policymakers. So a lot of work still ahead of us. But I want to draw out something you mentioned earlier around, there's so many new solutions now. Are folks even adopting them and using them?
Right.
If an employer even intends on purchasing one of the many solutions out there, they end up just not even seeing the desired engagement. So can you talk more about what's going on here?
Yeah. Okay. So this remains a very challenging problem. And I think that payers recognize that employers are very smart on this as well, where, there's a lot of effort, a lot of organizational effort goes into evaluating these, sometimes RFPs, making decisions, buying and then launching, all of the operational investments that go into standing up something like this, and vendor management, all of the processes that go into this that are very time consuming, labor consuming, cost consuming, and then potentially producing friction for the employees, which is the worst thing in the world, and the absolute no, and yet it happens. And then at the end of the day, very few people actually end up using it. And you would think that this, we've seen this play so many times that we would get smart to it. But I think in many ways, vendors have gotten very smart at, convincing employers, payers, others that folks will use their solution, and looking at other evidence of it. And, it's a tough scenario. I think that, first and foremost, there's a myth that if you build a digital front door, if you build a navigation approach, if you send folks, if you decide where folks should go, and make it easy on the front end through some kind of a portal or a digital front end, that will solve the problem. And I think what we're seeing now is, and this would be my controversial idea of the year. I give you one a year. And so this myth of the digital front door, that somehow the problem is really navigation, that if we could just navigate people, we would see better adoption and better ongoing retention. And the truth of the matter is that even if you can get folks to adopt, to engage, to step in and say, yes, I will try this. Yes, I think this might work for me. The challenge becomes that people don't just have behavioral health problems. They have many different things that they're facing, many different challenges, could be physical, could be other kinds of things. And so when there's no integration behind the front door, when the inside of the house is not integrated, then the user, the employee, the member is left with 8, 9 different experiences that they have to navigate. They have to do this for their diabetes, this for their behavioral health, et cetera. And so they drop out. They delete the app. They complain to the employer. So at the end of the day, to answer your question, at the end of the day, people will use what is relevant for them in their lives. And the arrogance that we continue to see from digital health of like, we know what's best for you. We'll tell you what to do. We'll and that arrogance isn't just on the member part, but a lot of digital health companies will approach employers, they'll approach payers with that same kind of arrogance. We'll solve your problems, just give us all your data, which they're laughed out of countenance in the employer space for making that kind of request, rather than understanding the gaps and the challenges and trying to solve those in a kind of a fitting in like a puzzle piece to solve that. So, I think that ultimately, the challenge around adoption that we continue to see, around engagement that we continue to see, is a problem of relevance. Solutions are still not maintaining relevance in people's lives. They're not fitting into what matters to people rather than what's the matter with people. And so how do you get to that relevance then? How do you get to this point where you actually continue to be important to the people who are trusting you to help them? How do you continue to be important to them, to be valuable to them, be relevant in their lives? And that requires not just fingerprinting or matching solutions to them or matching user journeys, as is the standard digital health playbook, but it really requires adapting as they change dynamically. And that's where a lot of the power of consumerism comes into play, where learning those lessons from retail, from consumerized sorts of experiences, learning from the TikTok, experience, from the experience of people that use things because they like to use them, rather than things that they're forced to use. I don't know about you, but I don't sit around poking around in my health plan portal, seeing what sort of fun things I could get out of it. And so I use it because I have to and under duress. Whereas these digital health solutions really need to adapt and become the sort of thing that I want to use because it drives joy, value, and relevance in my life.
That's such a great analogy. We focus a lot on driving folks to the digital front door, but it's like, oh, what happens once they're inside?
Right.
Can we talk a little bit more about what buyers are going to do about this?
Yeah. So I think first and foremost, buyers need to be discerning and very demanding of their partners in several key areas. Number one, recognizing that these partners are not going to set digital strategy. If you're one of the big health plans or even regional plan or a serious player, a partner cannot assume that they're going to set your strategy or predetermine a path for you around what integration or operational, what deployment looks like for you. But you've got to, I think, demand some flexibility. I think you need to demand, we've talked a lot about value-based care. At the end of the day, value-based care is often very watered down in its actual deployment. And anybody who's inside the sausage factory will tell you just how messy that gets and how really very little is put at risk in these relationships, and much more needs to be put at risk to drive outcomes. I think there should be an expectation that partners cover multiple conditions, that they do so with minimal operational intervention, that they provide data and analytics in real time, that they integrate across clinical and non-clinical platforms, that they deliver data intelligence that they normalize data and deliver it in a variety of formats, and that they put their outcomes at risk, including clinical outcomes at risk, and that they be very, very clear and transparent on what constitutes engagement and adoption, and specify those things and make sure that they align with what's important to the health plan, either along the things that will improve quality, say, for example, in the government lines of business, or will improve total paid claims within the required time horizon, or drive other factors that are very, very important to the payers and the employers, and do so in a way that's consumerized. And I think that if buyers really need to insist on that. And I think what we'll see is the digital ecosystem migrating to meet that.
Dr. Manishwala, this is really great advice for the payers in the audience. And it sounds like that payers in general are becoming more sophisticated. But you mentioned this consumerization of behavioral health care. Can you talk a little bit more about that?
Yeah, so I think that we've seen big tech come in and try to deploy in the healthcare space. And so far, we're seeing some evolution there, but so far that has failed several times over. It will ultimately succeed, I think, but the failures have taught us a lot, which is that you can't just take a consumerized experience and plug it into healthcare and expect it to work. And so there's been a recognition within healthcare, health plans especially, that we need to consumerize. But the experts on consumerization, the Amazons, the Apples, Googles, haven't yet figured out how to deliver that in the healthcare ecosystem. I mean, we're making a lot of progress in that space, and that's a great thing. The rising tide will float all boats. On the other hand, it's very, very clear that the absence of a consumerized healthcare experience leads you to deep dissatisfaction, massive disengagement, and portal-like experiences. So that's not going to work either. So what's the answer? And I think the answer has to do with experiences from consumerized healthcare, and applying those retail consumerized healthcare experiences to B2B2C environments. And you see this with a lot of solutions in the health space where people are paying out of pocket. And it's part of the reason, we at Dario made a decision to evolve a direct-to-consumer healthcare solution into B2B2C environments. And what that does is it identifies the factors that people who are already receiving services from health plans and yet are willing to pay out of pocket because they want something better for their health. And how can those insights, how can those longitudinal insights be used to really drive a superior experience in the payer space and the employer space around health for multiple conditions. And that I think is the right application of AI, because I think everybody at the conference hopefully is aware that AI is really only as good as the maturity of the data, the quality of the data that feed it, the longevity of the data that feed that, and the experts who annotate it. And so if you have long-term consumer-driven data around how people use these things, what they like, what they don't like, and how those things adapt and change over time at a very individualized level, and you can apply that then to the payer populations, then that's where you're going to get value. Because at the end of the day, people want solutions that are simple, that are relevant, that are engaging, but that work for healthcare and that work within healthcare. And that last part is what I think big tech hasn't yet been able to solve, but direct-to-consumer healthcare has. And it's also the reason why you see a lot of M&A activity in that space as well, at least pre the current environment. And so that's really where it is payer sophistication is around demanding consumerized experiences, demanding engagement, demanding that capability. And I think that's the right thing. And as payers look at partners and vendors in the space that don't deploy in a direct-to-consumer way, they should be asking themselves, why don't you do that? Well, why can't somebody just walk in and buy this? And I think that is a very legitimate question.
That makes a lot of sense.
Yeah.
I want to go back to, you'd brought up multi-condition solutions a few times now. And I mean, we've been talking about physical and behavioral health integration forever.
Yes.
So what exactly is the answer? Should payers just be starting with multi-condition solutions?
Yeah, well, I mean, we've made a big bet in this way. We think yes, they should. There used to be this trade-off where you'd go after individual conditions because you wanted best-in-class outcomes. Then you'd figure out how to integrate them. Ultimately, you fail, and then you go back and you sort of say, all right, well, we'll deal with that, the lower kinds of outcomes you see with multiple conditions, and we'll partner in that area. And that trade-off, I think, is dissolving now, where best-in-class kinds of outcomes are possible with multi-condition whole health approaches. And that's really, I think, the innovation that we're bringing to the space here on our side. And, we see others moving in that direction too, which is great. We want that. But, fundamentally, we've been talking about this for a long time because healthcare broke healthcare. And now healthcare is proposing to fix healthcare. And people should scratch their heads and say, wait a minute, is that really going to happen? And so simplicity, relevance, they really need to be the driving factors here. And people do have multiple conditions. Most people who have one condition have more. 40% have multiple conditions out there. And those conditions don't just co-occur, they interact with each other, and not just mental and physical, but physical and physical and mental and mental. And because of that level of interaction, the only way to solve the whole health problem is to deploy integrated from the start. But the problem is that's very hard to build solutions for that. So I think payers are left looking for unicorns. And I think, I believe we're one. And I think that, deploying against those multiple conditions at once up front is the right approach, because it's simple and it allows the experience, the personalized journey to be relevant in that person's life. And I also think that with this integration question that payers just have to expect and demand that vendors, that partners deliver data and intelligence, in the time, in the place, in the format, in the frequency that they need for their clinical platforms, that folks need downstream in order to just, avoid these disruptions in workflow. Payers spend a lot of time and energy focusing on care models. And, there's a question about whether that ultimately produces value. I think people do ask that question. But whatever the answer to that is, a partner can't disrupt those care models. A partner's got to be able to work within them in a very seamless way and really accelerate them. And that's what we need. That's what we need for integration. And unfortunately, there's not a lot of players out there doing that. But, I think the good news is as the payers get more sophisticated, they're going to demand that. And that's going to really push the ecosystem forward.
These are really important themes. but I'd be remiss if I didn't ask you more specifically, how is Dario Health applying the considerations that you've brought up today with the employers and plans that you work with?
Yeah, so we deploy multi-condition solutions, and we do so in a way that is integrated for them. We use an approach called Dario Exchange, which allows us to normalize the data. We push our data real time into the cloud. We normalize those data in a variety of formats, and then we can deliver those to our partners in a way that doesn't disrupt. We can push those through the application itself. We have web-based experiences that allow payers to look at that. We can deliver it in a way that delivers on and drives quality. And so, integration as a native capability is a core part of Dario's value proposition. Multi-condition outcomes and value-based care are core components of how Dario delivers outcomes in a dynamically personalized way. So, at the end of the day, we say that we're basically changing the healthcare experience by putting people at the center of a very simple, continuous, and connected care for health. Yeah.
Excellent. Thank you so much, Dr. Manajwala. As always, I learned so much from our conversations. I'm confident our audience did as well. And thanks so much for sharing these great insights.
Yeah, it's great to see you, Salome. My pleasure.